This week on the BackTable podcast.
It's a little bit like you're putting the catheter through the bladder into the upper tract, and then there's like holes in the catheter. I mean, it's like how confident are we that we've sampled the upper tract and there's suspicious cytology or positive cytology on one side? How confident are we that it's actually from the upper tract?
That's always the question.
I mean, I don't know. So I generally don't do selective cytologies. I will if I'm chasing a positive cytology and a bladder mapping was negative. But if this patient has CIS and they're coming to see me, they've been through 3 or 4 lines of therapy, I get a CT urogram and cytology. CT urogram was negative. I wouldn't chase the upper tracts, but I probably would remap the bladder with the blue light cystoscopy and prostatic urethral biopsies.
Would you random bladder biopsies and prostatic urethra even if it looks negative?
I would. Yeah. So, this is somebody that's coming to see you. They have a history of CIS. Who knows how much of that CIS they've cleared? They have a long-standing history. So if we're trying to get this patient clear and save them from losing their bladder, then I think that would be a good first step.
Welcome back to BackTable. I'm Vignesh Packiam. I'm excited to have a great tumor board session today with 2 amazing urologists, Dr. Mark Tyson and Dr. Sarah Psutka. Can you give us a brief introduction of yourself?
Well, Vig, thanks so much for having us. I'm so excited to be here and to get to talk about bladder cancer with you both. I'm Sarah Psutka. I'm a urologic oncologist at the University of Washington, and I spend a lot of time thinking about how to make patients fitter for surgery, so kind of getting into that prehab space. But non-muscle invasive bladder cancer is near and dear to my heart, so excited to chat.
Awesome. Yeah, thank you as well, Vig and Sarah. Delighted to be here. My name is Mark Tyson. I'm a urologist at Mayo Clinic in Arizona, and my clinical and academic subspecialty interest is in non-muscle invasive and muscle invasive bladder cancer.
Wonderful. So non-muscle invasive bladder cancer is getting more complex every day. We have more and more agents. It's a good problem to have, but it's complicated to manage. So I wanted to pick your brain on some cases and see how you think through these situations. So let's say we have a pretty standard patient, 74-year-old male, average age for bladder cancer. Referring urologist does a TRBT. He finds multifocal T1 and CIS. Not really clear what the volume of disease is based on his op note. Patient comes to see you in the office. Can you walk us through what your first steps are?
Yeah, so I think first things first, when you hear high volume T1 plus CIS, all of the bells go off that this is a patient who very much needs to have a thorough staging and evaluation. So you really have characterized that disease and you make sure this is one of those moments where making the right decision at this point is critical because it will change that patient's clinical trajectory. So I think at this point, the first thing is you got to we do a path 3 review. And I think I talk to patients to say, at this point, we need to look back in your bladder and make sure that all of the disease that can be resected has been resected and fully understand everything, especially if there's not muscle in the specimen. But I actually re-resect all high-grade T1 irrespective of muscularis propria in the first specimen. I just think I call it a quality check. I tell the patients before I take them to the OR, if I find high-grade T1, even when I'm doing your first resection, 4 to 6 weeks later, we're going back, and that's to make sure that we didn't miss anything because of that historic data that 25% of people are upstaged. But I think also I want to be thinking about the prostatic urethra, and I want to make sure that the upper tracts are staged. And I do get a chest CT, even though the likelihood of pulmonary metastases is low. It's more because I want to have a baseline so that I have something to compare to in the future if and when we get further CTs down the line. So I think at this point, it's kind of start from scratch, do all the work, make sure you fully understand that tumor.
Yeah, I think most of us will have a low threshold to do a repeat evaluation. Let's say the patient did not have T1 disease. Do you do an office cysto sometimes, or are you still taking that patient to the operating room?
I think it depends on, I don't know what you think, Mark, but I think the volume of high-grade TA, if it's a larger tumor, I will still often re-resect those.
And are you doing those with blue light, or?
If there's carcinoma in situ in that first biopsy, absolutely, I do.
Any other thoughts, Mark?
No, I think Sarah and I see it pretty much the same. I don't routinely re-resect TA. So I'll read the op note if the outside urologist and there's somebody I know and trust, especially if they've done a complete TUR, it's a smaller tumor, then I might not re-resect that because there is some data in the BCG immunoablation setting where BCG can ablate residual disease. So if we think there's some residual high-grade TA, that's probably not a big deal. Just give them induction BCG. I'm not sure you have to totally clear it. But high-grade T1, obviously we're worried about the potential for muscle invasive disease. And so that obviously changes the trajectory for the patient. So I think re-resection is very important, like Sarah said, for all high-grade T1s.
Yeah. Let's go through some different potential scenarios once you're in the operating room. And to be honest, I don't know the best answer for this. Let's say bladder looks really good. You see the prior scar from the site where presumed T1 disease was. Are you doing a biopsy of that area? Are you doing a full loop resection? Are you re-resecting the entire scar? Walk us through that.
So I honestly will usually re-resect the whole scar, especially if there wasn't muscle. If it looks like, sometimes you have those sort of little dystrophic calcifications and you'll sort of have one area where it looks like that was truly where the stalk was. And I'll cold cup that just to make sure I don't get cautery artifact. Because I do think a lot of times you resect the scar and you just get that sort of denuded epithelium and you don't get anything definitive. But I otherwise just like taking the loop and doing the sort of staccato method. And basically I tell my residents it's like Mohs surgery and just shave it down until we see some muscle fibers. Personally, that's my preference. And then I will often take a satellite biopsy sort of right next to it because I think sometimes you get that sort of halo of CIS and I kind of want to make sure that I fully understand that.
Yeah, I think it's tough because we want to sample muscle. We want to make sure we're not missing occult muscle invasive disease. But a lot of the time these scars come back benign and we'll see a rim of CIS, but I think it still seems to help these patients. Let's say we find a lot of CIS in the bladder, with or without blue light. Do you think it's important to resect all of the disease or just sample some and let the intravesical therapy handle the rest?
I generally try to resect all of it. I'm not sure how important it is for CIS, but I think it's an assumption when you see something light up on blue light that it's CIS. It could be invasive disease. So in general, I try to resect everything that we see. Now, there are those patients that have very high volume disease and they're heading towards a cystectomy anyway. I may not in those situations. I may just get a representative sample and the patient's really not going to go for intravesical therapy anyway because they have symptoms or they can't tolerate it or they've been through a lot already and now it's time for cystectomy. So in those cases, I may not, but generally I try to.
Philosophically, to me, it kind of makes sense to try to get rid of as much cancer as we can so that the intravesical therapy works, but there's definitely no answer. I don't think a trial has actually assessed that rigorously. So now I have seen this. Sometimes it can be a little frustrating. Let's say we didn't do an office cysto. You go to the operating room, you see a rim of tumor around the ureteral orifice. You're not totally sure if there's more going inside. What do you do then?
I think that's a really challenging situation because the way that you manage the UO has implications for that patient's bladder and upper tract health. My practice has been to resect on cut and not cauterize and basically just take the UO. I was having a conversation with somebody this morning actually about this, about do you stent or not stent? And my practice has been to try to avoid stenting, but then if it looks like it's really narrow, I will sometimes put a stent up just to try to avoid that stenotic UO situation because that can be a really tough problem later on if that scars down and you end up threatening the function of the upper tract and the drainage and then you're in there trying to sort of resect to find the UO. That can be really hard. But in general, I know the level of the evidence for sort of the risk of upper tract seeding with a stent after an immediate resection, it's low. It's retrospective data, but I still try to avoid seeding the upper tract if I can.
I cringe a little bit at putting a ureteroscope in there, but that would be a definitive way to rule out the extent of upper tract involvement.
If there is tumor coming out of the ureter, I generally will scope them just to understand what's going on. But it's tricky. And so the upper tract guidelines do say that, though, if we have concomitant upper tract and lower tract disease, generally what I do is I will take care of everything. I like to take care of the lower tract first, and then I will rinse the bladder a couple of times, just on continuous flows. You hope that there isn't anything floating around, and then I'll do my upper tract work. In general, that's how I've approached it. But I know that some people say, no, you should do the upper tract first and then clear the lower tract, so then you avoid the bleeding. So I think there's really not a perfect answer. You sort of have to do what you're most comfortable with.
Definitely case by case. The stent issue is a tough one because I've had stenotic ureters with stenting or without stenting. I don't think there's one right answer. I've asked some of my recon colleagues and there's no consensus on that. So,
and I think that the intravesical therapy probably causes also a fair amount of irritation. And I worry sometimes that actually exacerbates if a ureter is going to become stenotic. That can sometimes make it worse. I've seen that. So it's tricky.
Now, let's say you left a stent and you're planning on giving intravesical therapy. Are you going to leave that stent in through the induction course to try to get a little bit of treatment up there, or not an important consideration?
I'd love to hear what you think about this, but my personal reading of the literature is that doesn't really work terribly well. I think that in training we did that, but based on some of the animal studies that have looked at sort of transfer of like dyed intravesical therapy, we just don't get the kind of treatment in the upper tract that we would like to think we get with reflux from the bladder. So especially if there's upper tract disease, I'm going to treat that upper tract disease according to what it needs. If the upper tract is not involved, then that stent is in there just usually for 5 days and out. Leave it on a tether so that they can take it out at home and avoid another procedure in the office.
My thought process is sometimes there's some low volume papillary disease or CIS that kind of retrograde ascends up the ureter, and maybe that stent will let some treatment affect that, but it's definitely a soft call. All right, Mark, so this patient comes to the office, you've done the full restaging, let's say maybe you just find a little bit of CIS. Are you using any biomarkers to help guide the next steps, or are you just going based on the path report?
Going just based upon the path report. Saw the data at the AUA for the Vesta, I think the Valor Labs data for gemdosi versus BCG. In the biomarker selected population, gemdosi did better than BCG, which, I think we were joking about this yesterday. That might be the first time gemdosi took down BCG in any setting. I am trying to get that process up and running, that workflow up and running at Mayo in Arizona, but I'm not routinely using any biomarkers at this stage, primarily because I'm not convinced that at this stage there's like enough diversity in therapeutics to really make a difference. We're going to be putting most of these patients on BCG if we don't, gemdosi. So no, not typically.
Well, good segue there. What treatment options are there? Do you think that's true that we only have BCG, or are there other treatments you're talking about?
For a high-grade T1 with CIS?
Yes, newly diagnosed.
Newly diagnosed. We just, the Bridge trial just finished accrual, so we were very enthusiastic about trying to put people on that trial, I think, especially for a lot of reasons. And one, I think that question needs to be answered, whether or not gemdosi should be used in the frontline setting, but also in the setting of the BCG shortage. It was a way of getting more people treatment. Kudos to Max Cates and everyone who did that and ran that study. But in general, if it's a high-grade T1 with carcinoma in situ, I'm having the conversation about upfront cystectomy versus BCG. And at this point, I don't think we have anything else that I would consider in the frontline setting.
Do you think about clinical trials, or, the new CREST data is interesting as well?
Yeah, and we'll see, once that's ready for prime time, I think that's going to be a conversation we will be having. But at least at this point, for BCG naive, we don't personally have any trials open at our shop in that space. Obviously, I am one of those people who believes very strongly that if there's a trial available, we should be talking to patients about it. But until we have our next round, right now it's BCG or bust.
Yep. All right. Well, let's say, you don't have BCG, complete shortage. What's your next step in that situation?
Like Sarah said, usually a trial. So we were enrolling on Keynote 676 and Patapsco. We weren't enrolling on CREST, but for somebody who has high grade T1 and concomitant CIS on re-resection, obviously very high risk phenotype, this is somebody that I would consider an IO therapy combination with BCG clinical trial concept as a hedge against metastatic disease. There's a non-zero chance of metastatic disease in a patient like this. And so if they were young and healthy and otherwise willing to take on the systemic risks of IO therapy, I would offer that. I'm not necessarily saying I would recommend it, but that's certainly an option. Otherwise, BCG would be the go-to for somebody with residual CIS. If we're out of BCG, then we're kind of stuck, because Max had some really nice phase 2 data for T1 patients, predominantly T1 patients in the BCG naive setting. I think a 25 patient cohort that he published last year or the year before, and the CR rate was impressive, like 90+% at a year or something. So gemdosi was, in short, based upon that phase 2 trial. But, that's problematic for some people, given docetaxel and there's challenges there too. So I'd have that conversation with the patient and say, it's going to be a long day in the clinic, and it's 2 chemotherapies, and it's not easy sometimes. And so, it would be a dialogue, but that would probably be where I would ultimately land if they weren't candidate for cystectomy, if they declined a clinical trial and there's no BCG available.
I guess in your mind, is the data for gemdosi compelling enough that you think that's a reasonable choice rather than, referring to another center that has BCG?
Great question. I think Max's gemdosi data is compelling in that phase 2 trial that they published. And obviously, we're awaiting the results of Bridge. But because there was a lot of T1 patients in that trial. And this patient has residual CIS, that's probably shouldering the original lesion. It's not like the rest of the bladder looked okay. This patient's fairly young, 74, hasn't tried any other intravesical therapy. So yeah, I am leaning for this patient. I'm leaning a little bit more toward intravesical therapy. And yeah, if there was somebody in town that I knew had BCG, which is not the case for me, then I would definitely make a referral for consideration of BCG. But I I wouldn't hesitate to do gemdosi in this setting.
Yeah, I find the gemdosi data to be relatively compelling, and we have some good retrospective outcomes, and the prospective data is really lining up with that. So I personally have zero qualms giving gemdosi in that situation. But of course, if you have BCG, that's the level 1 recommendation that those patients can get. So let's say, BCG shortage happens, patient gets gemdosi, maintenance for 6 months. They recur. Now we have BCG, patient gets induction maintenance of BCG, another small recurrence with CIS now. Bladder function starting to get a little bit worse, some more nocturia, some more frequency. How do you think through the next options for this patient?
So it's CIS only recurrence within 6 months of induction BCG in a patient who's already had induction and maintenance gemdosi. And at this point, I think this is where you start to have a very thoughtful conversation with that patient, not only about the now, but about the future. And this is where having a really good relationship with your patients, I think, helps. And the one thing is this patient would be sitting down and it would not be the first time I would be bringing up cystectomy. So I bring up cystectomy early and often, not because I want people to have a cystectomy right away, but because when it comes time to talk about it when they really need it, I don't want that to be the first time they're hearing about having their bladder removed. Because I think that it takes a long time for people to get to the point, especially someone who has non-muscle invasive disease, where bladder preservation, they come in the very first time and they say, my goal is to die with my bladder in my body. I say, okay, I can meet you there. But I want you to hear the conversation about cystectomy so that if we ever have to talk about it and we don't have any other options, you already kind of know what the spiel is. Just because mostly that conversation is such a dated, heavy conversation that I think it's a lot for people to not just walk away from completely overwhelmed. So in this situation, obviously, immunotherapy, unless you can get to, we can talk about with just a little bit of CIS, I would have a conversation about cystectomy. I don't think this patient needs a cystectomy, but unless the bladder function and their quality of life is driving them towards that, where they're not sleeping, it's affecting their cognitive function, they're, unable to do the things that they enjoy, it's disrupting their independence at home. So at that point, I think bladder removal is a quality of life option. And the cysto data could be used to support that conversation, obviously, that was recently presented at the AUA. I think that
Absolutely.
That's very compelling, that taking out the bladder in someone with BCG unresponsive high-risk disease is associated with improvements in physical function and quality of life.
I think it's smart to bring up cystectomy early. And it's part of the education about the disease process. But let's say this patient's very motivated to keep their bladder at this point.
Well, the nice thing is we have options, right? So I think in our practice, we would be talking about nadofaragene. I think that now I will say that in someone who has a really irritated bladder, you're going to have to work to make sure that nado stays where it's supposed to stay for an hour. And so you want to work on maximally controlling their bladder symptoms and the sort of spasticity of that bladder in order to get as much bang for your buck as you can get.
So just to interrupt there, is that a consideration that you're making for these specific patients? If they have a lot of tolerability issues, are going to steer a little bit away from that? Or do you think you can overcome that?
I think you can overcome it.
Okay.
But I actually draw on Mark's data from that. It was just published with the rectal benzodiazepines. I think that I've found to be very, very helpful. We also have BNO suppositories, which are compounded locally that we can utilize. And then we'll just make sure that they're obviously on maximum antispasticity medications, whether it's an anticholinergic or a beta-3 agonist. And also thinking about, hydration and just trying to optimize their lower tract. Definitely think about a clinical trial. In the setting of a BCG shortage, we are not using a lot of Anktiva, to be totally honest with you, just because I think that we are limited especially in our region, with how much BCG we have. So it's not as much of an option. And I think the cost considerations come into play a little bit from a pragmatism standpoint. I do think, though, that one of the benefits of the nado is that it's a once quarterly drug. So you're not getting, 6 weeks of sort of increasing bladder intolerability. You sort of, it's one and done, see back in 3 months. And I think that especially the real world data that's recently been published shows improved durability compared to even the initial study that led to its regulatory approval.
Yeah. No, those are great points. And do you have the same type of thinking about bladder symptoms and how you're thinking about these treatment options?
Yeah, I agree with what Sarah said. I think laying the groundwork for cystectomy is important for this patient. For this particular patient, I would probably do one more course of BCG, patient that's BCG exposed. If I could give a full induction course, I would land there. If I was really short, then another course of maintenance. But
let's say he was BCG unresponsive. He got an induction and a maintenance.
Then and in that case, then I would probably not give more BCG.
Although there's some interesting data from Ashish Kamat that
Ashish's data,
even in well-selected patients that are BCG unresponsive, you can get some nice responses.
And that's why I say probably not. I think for this particular patient, I generally, if they were exposed, I would generally start thinking about a trial, like Sarah said. There's a bunch of trial concepts. Core 8, Legend's got a cohort coming. Advance 2, I think, just might have a cohort coming too. So there's options out there still for BCG exposed, and of course the GAIN trial, Eugene's trial, which we're going to open and support. I'm excited about that too. So if there wasn't a trial,
can you tell the audience a little bit about that?
Yeah, so GAIN is a GEM BCG concept. It's the phase 2 data for that concept looked really good. Like the gemdosi data, phase 2 data looked like 90+% CR
That was
rate.
incredible. I think 93%. I mean,
So I mean, if I have GAIN open and the patient's just interested and they're exposed, BCG exposed, then I would not hesitate to land there, or just give more BCG if I had it and they were not, let's say they're not interested in the clinical trial. But if they were BCG unresponsive, then like Sarah, I talked to the patient about all the options, natafergine being one. We do use nogapendican as well, and I use both of those probably about half the time when the patient's not getting gemdosi or a clinical trial. So I really think it's great for patients right now to have kind of a choice.
Yeah.
A lot of choice.
Yeah. I'm not going to try to say NAI like you did nicely, but with the BCG shortage, I totally agree. It's tough to kind of rationalize using an agent that's also using BCG, but now they're making a push to give recombinant BCG. I don't know how much data there is that's very strong to support that. Is that something that you guys are using in your practice?
Not at this point. We're not. Are you?
Yeah, we're opening the EAP. Yeah, we haven't started using it yet, but we're going to open it, and I'm going to use it because I think it's an opportunity for me to go back to 6+3. And I agree that there's questions about comparative efficacy, but right now in my practice, I'm doing 5 of 6 doses for BCG and 2 of 3 for maintenance routinely. And right now, the shortage is so bad, and especially as our kind of winter visitors come back from their cooler summer climates, the demand increases, and so I'm doing half dose. And so the recombinant BCG program is an opportunity for us to go back to full dose 6+3. So we are opening it. It's budget constrained, which makes sense because they're giving you BCG, and it's not like they're going to also pay for your coordinator. But they're not asking for much either. So there's just kind of grade 3s. So we are opening it. We'll see how that experience evolves. But yeah, I don't know how well it's going to work relative to Tice. I mean, there were some strain differences between Connaught and Tice too. So, yes. And there probably is strain differences between Tokyo and Tice. So I'm just conjecture. I'm just thinking. I'm not saying I've seen any data on that.
We just need the prime data.
We need the prime data, right?
BCG is so interesting. I mean, it's been around for a long time, and there's so much to learn about it.
Absolutely.
These intrastrain differences and how to optimize it. Let's say we had a little bit more of a textbook initial BCG unresponsive patient that has only received BCG and maybe failed after a year of maintenance. So you have gemdosi as an option. How does that discussion kind of change in that context?
Well, okay, so you and I talked about this a couple nights ago, and the gemdosi data is compelling, and it's multi-center, and it's large numbers, and high-grade complete response, high-grade recurrence-free survival rates of 50+% in 2 years is certainly better than anything that we've seen in the prospective trials. My question is whether the prospective trials, are at a disadvantage in when you're comparing across high-grade recurrence-free survival at 2 years. Are those trials disadvantaged by prospective study designs and high-quality data and all these things that we expect from prospective trials? I mean, so all that to say this, I generally don't lead off with gemdosi because the quality of the data for pembro, natafergine, nogapendican is better. It's higher quality. These are phase 3 registrational studies. And so I generally will talk to the patient about those first, actually. But I'm not a gemdosi unbeliever. I will also talk to them about that, and that the data is pretty good and it's pretty easy to give. And for us at Mayo, it's not hard to give. I mean, gemdosi is difficult, I think, for some of our independent practice colleagues. But it's not hard for, I don't think, the three of us to give. But so I have all those conversations with patients, but I generally kind of land on a clinical trial or one of those other FDA-approved drugs first.
Yeah, it's interesting. I think we preferentially start with Gemdosi for a couple of reasons. One, I think it's something that our office, from a workflow standpoint, is just very comfortable and accustomed to giving, and we can get patients through it well. I think that the 2-year sort of durability is something that has pushed me, and I do recognize the differences in the quality of the data. And this is the tricky thing: we can't compare across trials because the populations that got into each of those studies were so very different in terms of their prior treatment burden and just even we know that there are differences in who gets into trials and who doesn't. I think that the real world data that's coming out, sort of the phase 4 EAP data, the sort of the real world NATO data, is interesting because looking at how these drugs are actually used in the real world and what responses we are seeing in clinical practice off trial, I think is interesting. And the fact that it was better, the durability especially, was better with NATO after in the real world data than it was in the phase 3 or in the registrational studies. Interesting. But I maybe this is just the Canadian in me, the cost piece comes into play. I have a really hard time with how expensive those drugs are. And I have patients who are selling their homes to pay for their medical care. So that does come into it. And I also think about keeping those drugs. I think if we can salvage somebody with Gemdosi and have a good durable response, and we keep all of those other drugs in our back pocket for when we need them later. So I go into it with no preconceived notions about what patients are going to tolerate. And sometimes a patient says, look, I'm coming from Alaska. I can come down 4 times a year. I can't come down for 6 weeks and then once a month. And, it's just that's not something I can make happen. And so we have to think about like the practice settings that we're all working into. But it's interesting. I do think at this point, in the absence of comparative data, it's the logistics that end up oftentimes driving patients towards one decision versus another. So I'm a heavy believer in enrollment to clinical trials if I have them available. We are also opening the Creator EAP, and there's going to be a TAR 200 sort of further registry that will open up if and when we get the registration on that. But I think that right now, I guess what I'm seeing is that most patients are definitely starting with Gemdosi, and then we're going to sort of ratchet up as we go.
Yeah, I think really great points. I personally find the Gemdosi data to be pretty compelling. There's multiple large retrospective multi-institutional series that are consistently showing 1-year complete response in the 60 to 70% range. There's recently a study in Europe also where they reproduce this as well. So I find that interesting, but totally agree with your point that it's not prospective data, and it's tough to do these cross-trial comparisons. But when I walk patients through these numbers, a lot of them end up electing for Gemdosi. But very good point about the logistics. Sometimes that's going to end up shifting the decision considerably too.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC, that's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.